Well, it's great to be here. It's wonderful to see such a group, so interested in shelter medicine and high quality, high volume spay neuter. I want to start out giving you a little bit of history associated with the Veterinary Task Force to advance spay neuter. For those of you here last night, where I mentioned how that came about. The task force was really the brainchild of your own Leslie Appel and Carla Brestol from Humane Alliance that thought it was time to pull together a national group to just look at the concept of high quality, high volume spay neuter. And that group met first in 2006, December of 2006, in Ithaca, New York, Cornell University. And what they tried to do, number one, was really define the concept of high quality, high volume spay neuter and link the two together. There's a huge difference between high quality, high volume spay neuter and high volume spay neuter. And there was recognition that certainly at that time there was a fair amount of opposition to the spay neuter clinics that were being established across the country. A lot of private practitioners opposed, a lot of state boards opposed, and actually bringing practitioners up on charges for doing things that were totally appropriate. They were just different than what was the norm in private practice. And so part of the concept was, let's really define this area of high quality, high volume to try to make it a legitimately accepted component of the veterinary profession. And the major part of doing that then was developing guidelines that kind of set a standard, all right, with the assumption that all the programs that could meet these guidelines really would fall into this definition of high quality and really should have no concerns. All right. The task force was also charged with developing and distributing training and recruitment strategies, because one of the struggles that spay neuter clinics were having at that point in time was finding people that could do more than a half a dozen surgeries a day. Finding people that had the skill set for high volume. And so the task force put together some training and recruitment strategies, and then began looking at some epidemiologic studies. There were 22 veterinarians on that original task force. There were board certified surgeons, board certified anesthesiologists, board certified internists, critical care, board certified people in critical care, epidemiologists, and then a good mixing of just high volume surgery, surgeons that were already out in the field doing high volume spay neuter. And tons of effort, literally thousands of hours, went into literature search, 3 face-to-face meetings, one here, the first one at Cornell, then one at LSU, and then the third one at Penn. Too numerous to count conference calls, ultimately resulted in the publication of the first edition of the guidelines that was published in the Journal of Veterinary Medical, AVMA Journal, July 1, 2008. But knowing that nothing in veterinary medicine remains static, the intent was that we would at some point in time update these guidelines, that it wasn't, okay, we've done that job, it never has to be done again. There would be a day when things had changed enough that they needed to be updated. So in 2013, the Association of Shelter Veterinarians reconvened the Spay Neuter Task Force. This time there were 20 veterinarians on that task force. The purpose of the task force was very narrowly defined now. It wasn't to do all these other things. It was simply to revise that guidelines document. But it still had board certified surgeons and anesthesiologists and internists and critical care people and practicing high volume spay neuter surgeons in it. Both task forces, the efforts of both groups were funded and supported by PetSmart Charities and the ASPCA. So last fall, the task force had finished their work for the most part. They submitted the guidelines, the preliminary draft of the guidelines, back to the ASV board. You know, it has the name, the Association of Shelter Veterinarians, on and on and on. It's not the Spay Neuter Task Force guidelines, it's the Association of Shelter Veterinarians Task Force. So it had to go beyond just the work of that team of 20, and it had to go back to the ASV board to make sure the ASV board was in agreement with what this new article was going to say before they felt comfortable having their name attached to it. Well, there was an exchange back and forth. The members of the ASV board submitted questions. The task force members answered those questions. And after a process that lasted just a few months of back and forth, the ASV board voted unanimously to accept the guidelines. In early 2016, the guidelines were submitted for publication to the AVMA journal, and the 2016 version of the ASV Spay Neuter guidelines was published in the July 15th edition of the Journal of the American Veterinary Medical Association. So almost exactly 8 years, and it's amazing how fast that time went. Almost exactly 8 years from the time of the first publication, the second publication hit the press. All right, now I'm assuming, although that's kind of dangerous to do, I'm assuming that many people in the room are familiar with that initial document and that probably some of you have seen at least the revised document. But knowing that there's probably people in the room that aren't that familiar, I'm going to kind of go through in some level of detail, at least the revised version. The original version, the 2008 version, was divided into 4 major categories. Guidelines for preoperative care, guidelines for anesthetic procedures, surgical care, and postoperative care. All right. The 2016 version has the same broad topics and added 2 more. All right. The 2 more that were added are guidelines for patient care and clinical procedures. If you sat down and read both documents side by side, you would discover that really this guidelines for patient care and clinical procedures is really just kind of a reorganization of some components of the original document into the introductory component, if you will, of the revised document. The really new component, totally new component in the revised guidelines is the last section, the guidelines for operations management. All right, and that's how do you manage a spay neuter organization so it continues to improve over time. All right, and that's all new content. And again, if you were sitting down reading both documents at the same time, you would find that there's a lot of duplication. There's a lot of things that have not changed in those 8 years, but there's many that have. So you might take some effort if you tried to go through and read, okay, what's changed and what hasn't changed. You don't have to do that. Just read the new guidelines. The new guidelines have all the old things that haven't changed and all the new things that have changed. So our goal today is to give you an overview of each section, and then we're going to have a period of time at the end for questions and answers. And I'm the surgeon, one of the surgeons on the group. I'm not going to claim to be an expert in all of the areas. So we have other people that were on the task force in the audience that will be available to answer questions as well. All right. So the reality is that the Association of Shelter Veterinarians recognizes that high-quality, high-volume spay-neuter programs serve an underserved population, and they provide surgical sterilization to animals that are most at risk for continuing to contribute to shelter impoundment and shelter euthanasia. It's an area of the profession that's absolutely critical if we're going to continue to drop the number of animals euthanized in shelters each year. Again, last night we were talking about early 70s when the estimate was 22 to 24 million a year, which sounds really bad. And today the estimates are 3 to 4 million a year, which sounds really good compared to 22 to 24, and is still absolutely terrible. When you think about that, if you allow me to round up and say 4 million animals euthanized a year in shelters across the United States, and if you consider a 5-day work week, and I know shelter people work, 8 days a week, but if you consider a 5-day work week and an 8-hour work day, 4 million animals is 1 every 2 seconds. We're scheduled to give this talk over a 2-hour period. And in that 2-hour period, there'll be 4,000 animals euthanized in shelters in the United States. 4 million is a horrendous number. It's better than 24, but it's still way too much. Association of Shelter Veterinarians is committed to trying to get that number to continue to drop, and they recognize that high-quality, high-volume spay-neuter is still the most important tool in dropping that number. So ASV supports the continued development and growth of spay-neuter programs across the country, but they are committed to both components, high quality and high volume. If we ever want to destroy this movement, as I call it, we start putting greater emphasis on the high volume and less emphasis on the high quality. The only way that this segment of the profession has gained the credibility that it has, and it's now fairly well accepted across the profession, is by the emphasis on the high quality. Every single one of those animals that we do surgery on in high volume spay-neuter clinics deserves absolute excellent care. So it's got to be both. It has to be high quality. It has to be high volume. All right. So as I said, the ASV seeks to support high quality, high volume spay-neuter programs, and the goal of the publication of the guidelines is really to encourage veterinarian and public participation. All right. And what do I mean by that? That's more than wanting to hire more spay-neuter surgeons. All right, that's getting state boards to recognize that this is a legitimate practice area and not to prejudge. I made the comment last night about the veterinarian in a southern state that was brought up by the state board in her state on charges that included the comments, no veterinarian can do that many surgeries in a day and do them well. No veterinarian can do a spay that fast and meet standards. State boards have to recognize that what these clinics do is high quality. That's one of the major goals of the publication. We want governing agencies, we want funding agencies to recognize the importance of and the quality of what high volume spay-neuter clinics do. We want the private practitioners out there to recognize the quality and recognize that we serve a population that they don't serve. In fact, for the most part, we serve a population they don't want to see. All right? I don't think the statistics are still up there, but Michelle Antower mentioned this morning, 90% of the clients that bring animals to Humane Alliance have never taken the animal to a veterinarian before. All right? A private practitioner cannot lose a client they never had. All right? So we want those private practitioners, that small group, but they're still there, that small group that still resist the establishment of the Spay Neuter clinic in their town. We want them to realize that these clinics are not a threat. Not a threat at all. Of course, one of the purposes of publishing the guidelines is to encourage everybody involved in high-quality, high-volume spay neuter to pay attention to that high-quality component. All right? So if you're involved in a spay neuter clinic, read the guidelines. If you go through your program and you recognize that there are things in your program that don't meet those guidelines, we want you to consider changing. We want you to ratchet things up a level so nobody can point a finger and say, but the spay neuter clinic in my town does XYZ, and then use that to condemn all of us. All right? So we want all the spay neuter clinics to meet the guidelines. The other thing to consider is, and this is maybe the tougher one, is that the majority of this document, the majority of these guidelines, aren't specific to high-volume clinics. There is no reason why anybody who does spay neuter can't meet the guidelines. So while it's not explicitly stated in the guidelines, they're just as appropriate for that private practitioner back home that does a half a dozen surgeries a week as it is the spay neuter clinic that does 50 a day. The guidelines are just as appropriate. And I'll bet, if people were honest, people know veterinarians who you wouldn't want to take your own pet to once you've seen them do a spay or neuter. All right, so ideally, over time, not only does it emphasize quality in the high volume setting, but it also starts to push higher quality in the private practice setting as well. Now, one of the difficulties is there are lots of different models of high volume spay neuter programs. All right, so we couldn't design the guidelines specific for one model. They had to be broad enough that they were appropriate for MASH style clinics like SOS, or mobile clinics, or standalone clinics like Humane Alliance, or shelter clinics, or the in-clinic clinics, the clinics that are inside a private practitioner. The guidelines had to be broad enough that they were appropriate for all different models. All right? So we had to keep a balance there. Broad enough to apply to every model, while at the same time ensuring that they promoted quality for every animal in each model. So, as in all clinical veterinary practice settings, attention to the details involved in providing patients with quality care during the entire experience, all aspects of the veterinary experience, is absolutely critical to success. All right? So we're looking at patient transportation services, record keeping, vaccination, patient handling and housing, infectious disease control, preparation for emergencies, follow-up emergency care, Those are all subjects that are dealt with under this broad heading of patient care and clinical procedures. All right. Under patient transportation, we heard this morning about Humane Alliance's transport program where 80%, is that right, of their patients are transported in from the outside. Many programs have transport programs. In fact, one of the things we'd love to see is more high-volume clinics having transport programs, because it takes a certain population density to support a high-volume clinic. So if you're in a city that doesn't have that population density, the only way to get enough patients to make the clinic be sustainable is to extend your outreach. But we're dealing with a clientele, many of which don't have transportation. You know, so that individual that's 40 miles away that doesn't have a way to get to the clinic is up the creek unless there's a way to get the clinic there, a transport truck or whatever. So when you consider patient transport, there has to be lots of consideration associated with both the comfort and the safety of the animals that are being transported. It deals with proper confinement of animals. It deals with securing enclosures. We've seen transport vehicles where simply animals are put in a dog crate, and a dog crate put in the back of a truck, and then another dog crate stacked on top, and another dog crate stacked on top, and then the truck makes a major turn. You know, the enclosures have to be secure. You have to have a system of identifying the animals. You know, it makes no sense, if you will, to show up at the spay neuter clinic and then at that point try to figure out which animal came from which group or which animal came from which person. There has to be a systematic way of identifying all of the animals that are being transported. All right. You continually read in the news about the situations where a child is forgotten and left in a car seat, or someone goes into the shopping mall and leaves their dog in the car while they run in to get a few things at the store, and 3 hours later they're still infatuated by the sale that's going on and the dog's dead in the car. There has to be proper temperature control. There has to be proper air circulation in these transport vehicles. Depending on the region of the country, it's amazing how fast the back of a transport truck can get to a fatal temperature. All right? So it can't just be any old truck that you just throw them in the back. It's got to have temperature control and air circulation. All right? Depending on the length of the transport, there should be a system in place to be able to monitor the patients in the vehicle. Now, that doesn't mean if the transport's 30 minutes away, that doesn't mean that every 10 minutes you have to stop and send someone to the back of the truck. But what if the transport's 3 hours away? There has to be a way to make sure the animals are still comfortable. All right, under record keeping, one of the first things the guidelines emphasize is that the guidelines are meant as a guide and are never meant to supersede state or local regulations. So while our guidelines point out things that probably should be included in record keeping, you may very well be in a state where the Practice Act requires much more than the guidelines ask for. In that situation, you go with the Practice Act. You go above and beyond what the guidelines. But if your Practice Act doesn't dictate, then go with the guidelines. All right, so it should, but the guidelines say it should certainly include a physical examination results, the body weight, what drugs are administered and by what route and what dosage, what surgical procedures are performed. The guidelines say that it's perfectly acceptable. In fact, it would almost be insane not to use standardized operative reports, as long as the operative reports have a method for you to modify. You know, okay, our standard is to close this way, but in this particular case, we had to do a different closure, and this is how we closed, and this is why. All right. And obviously, the record should include any abnormalities found before, during, or after the procedure. The guidelines say that it's always recommended for animals to be vaccinated prior to surgery. We don't try to get into the business of, okay, now what's the core vaccine? What are the vaccines you should use? We simply say that the American Association of Feline Practitioners has done that, and AHA has done that, and we recommend following the guidelines that they've produced from the standpoint of vaccines. All right, so in the ideal world, the animals are vaccinated before they ever come to the spay-neuter clinic. None of us live in the ideal world. Most of us in the high-volume spay-neuter world don't live anywhere near the real world. And so it goes on to say that vaccination at the time of surgery is appropriate. It is acceptable. Is it perfect? Is it ideal? No, but it's certainly acceptable. All right, so it's encouraged. If you get that animal that's never been to a veterinarian, it doesn't mean turn it away until the owner figures out they have to go to a veterinarian and get a vaccination, because that owner won't do that. It means in that situation, simply vaccinate the animal. You're still giving the animal protection through the vaccine, and it's acceptable to do it at the time of surgery. So patient handling and patient housing, you should always have systems in place to minimize the animal stress. All right, and that deals with separation of species wherever possible. It deals with, again, within the clinic, adequate temperature control and adequate ventilation. It deals with how you carry animals or how you move animals that are resistant, animals that won't walk on a leash, or animals that are fractious or want to eat you for lunch. You want to minimize noise and other environmental stressors as much as possible. Any of us that have worked in a veterinary environment know that noise is part of it, but there are ways to reduce that noise, to minimize the noise. The guidelines deal with how animals should be, how housing should be cleaned, and how housing should be disinfected between animals. You want animals that are tractable animals in individual cages or runs or portable crates or carriers that allow for good visibility and adequate space to stand and turn around. All right, you've got to be able to see the animals, when they're housed. It's perfectly legitimate to house litter mates or house mates together, but other than that, animals should be individually housed. All right, intractable animals or feral animals housed in traps the trap should allow for the administration of anesthetics without trying to manipulate the animal. You probably all have the traps with a little fork thing that you can put in and confine the animal and inject the anesthesia in the trap. All right. and they describe the special handling you should have to move anesthetized animals, so the head and neck are supported and maintained in straight alignment to provide promote optimal airway and the body continually supported. Between each patient, all equipment with direct contact, animal contact, should be thoroughly cleaned and disinfected with agents known to destroy common veterinary pathogens. Between each patient, anesthetic equipment should be inspected and cleaned and maintained on a schedule commensurate with the surgery volume. All right. Staff should wash their hands or change gloves between each patient, or in the case of dealing with a litter of puppies or kittens between each litter. All right, and if an animal has some minor disease process that's picked up on the preoperative evaluation, but it's still determined that that animal is an appropriate surgical candidate, all right, then that animal should be scheduled to undergo surgery basically at the end of the day after all the healthy animals are done. Again, to try to minimize the spread of disease from one animal to the other inside your facility. High volume, high quality, or high quality, high volume spay neuter programs should be completely prepared for those emergencies that happen within their environment. They have to have protocols in place. There should always be a veterinarian. When the animals are there, there should be a veterinarian present to triage and address any complications. And the veterinarians should remain, at least one veterinarian should remain on the premises until all the patients are extubated, sternal, and responsive. All right. So in the high volume setting, a veterinarian comes in, and lots of these settings, a veterinarian only works certain days of the week or whatever. The veterinarian comes in, and they've finished all the surgeries by 2 o'clock in the afternoon. That doesn't mean the veterinarian hops in his or her car and drives away. They hop in the car and drive away once all the animals are recovered and extubated and at least able to maintain an upright position. All right. Clinic staff and volunteers should be trained to recognize emergencies, and at least some of the clinical staff should be designated and trained in CPR on animals. All right. All the standard equipment and standard drugs and reversal agents should be readily available. You should have a crash cart, and you should have dosage charts so nobody's sitting there grabbing the emergency drug and then looking for a calculator to figure out how much do I give to this 8-kilogram animal, with dosage charts that just all you got to do is look across the line. All right. You should have regular practices, regular policies for dealing with complications and emergencies, if possible. And that we recognize that that's a big if. If possible, the clinic or the mobile unit or whatever should perform its own reexaminations. I'll give you a perfect example where that's absolutely impossible. Our program is a mobile program. We go to 24 different shelters, some of them as far as 2.5 hours away. All right. So we finish surgery at 4 o'clock in the afternoon. All the patients are back in the shelter. We're back in our truck, and we're driving home. And at 9 o'clock in the evening, one of our patients has a problem. We can't help that animal, and we can't even reevaluate that animal. But we have to have systems in place for someone to help that animal. So when we're considering starting to work with a particular shelter, one of the things that shelter must provide is a sign-off from at least one local veterinarian in the community who agrees to deal with any major complications or any reevaluations associated with the patients that we've done surgery on after we've left town. And if a shelter cannot get that from a local veterinarian, we don't work with that shelter. Has that ever happened? Yes, it has. All right? That goes back to the fact that high quality is as important, or more important, if you will, than the high volume. We could go to that shelter, and we could do surgeries, and if you do enough surgeries, you're going to have one bleed, you're going to have one crash, you're going to have some complications several hours after surgery, and all it takes is that one to give high volume surgery, a black eye in that community forever. So that shelter has to have someone who has agreed to see those clients. All right, those patients, I mean. In the event of patient death, the guidelines recommend that you attempt to do a necropsy, that the program should be notified of the patient death and should do a necropsy if possible. All right, under preoperative care. Preoperative care deals with patient selection, client communications, withholding food, and physical examination. All right. The first major point under preoperative care is who makes the decision whether an animal is an acceptable surgical candidate. And it has to be a veterinarian. All right. I know of situations where it's been the shelter manager or the manager of a high-volume clinic that has tried to impose those decisions. I've talked to some of our graduates that have gone into spay neuter clinics that have called me up and said, you know, the director of the clinic is saying I have to do X, Y, Z, whatever, and my response is always, I'll be a reference for you as you try to look for a new job. Don't put yourself in that situation. All right? The person that makes the decision, is this particular patient eligible for surgery, has to be a veterinarian. It cannot be someone without that background. All right? The guidelines say that for owned animals, they still recommend spay neuter prior to the first heat cycle, prior to puberty, but it may be best to wait until at least 4 months of age. Why is that? Then the animals have completed their full vaccination series. You have the greatest confidence that they're fully, as fully immune as possible before you bring them into that surgical environment. So for owned animals, the recommendations are 4 months of age, but still prior to the first heat cycle in females. All right. For shelter animals, the recommendation is prior to adoption, regardless of the age of adoption. So if the shelter is adopting out 8-week-old puppies and kittens, spay neuter them prior to 8 weeks. All right. Does that put the animal at at some greater risk of infectious disease? They're already at risk. They're in the shelter. All right? So prior to adoption. What you don't want, and I wish, we work with 24 shelters. We've been working, the number has grown over the years, but we've been working with shelters since the early 90s. And we still have a couple shelters that will adopt out reproductively intact animals. I wish I could strangle the people, but we're getting close. We're close to all of them that won't adopt out a reproductively intact animal. But I wish that was universal, that every shelter followed that. Do not adopt out a reproductively intact animal. The students think I'm cruel and heartless because I'll actually say to them, see this cute little kitten? I would rather have the shelter euthanize this cute little kitten than to adopt it out intact. Because if they adopt it out intact, 6 months from now, we're going to have 5 more cute little kittens from this one. All right? So, as cold and cruel as that sounds, I would rather have them euthanize it than adopt it out intact. Now, what I would really rather is just spay it. All right? Just spay it. You don't have to euthanize it. Spay it. I made the comment that in the shelter environment, spay neuter prior to adoption, but for owned animals, the ideal is probably to spay neuter at 4 months. Let them get the full vaccination series. If 90% of those owned animals are people that never take their animal to the veterinarian, then they're not getting the full vaccination series. And so I guess the simple way to consider it is when you're dealing with that population, the people that never take their animal to the veterinarian, consider them the same as shelter animals. You spay them when you get the opportunity, whether it's 6 weeks of age, 8 weeks of age, or 4 months. But you would never take one of those clients who, I've never been to a veterinarian before, and I'm calling and I've got this 10-week-old puppy, I want to bring it in to be spayed. Don't say, wait 6 weeks. In 6 weeks, you may never see that animal again. So consider those the same as you would shelter animals. Veterinarians always have to be in that decision of the veterinarian making the decision of, is this animal appropriate? Veterinarians also always have to weigh the risk and benefit of neutering a patient that has some mild infectious or non-infectious medical condition, upper respiratory disease, parasite infestation, subclinical heartworm infection. What we have to recognize in the shelter environment, and for most clients that come to high-volume spay-neuter environments, is that this opportunity you have for this animal may be the only opportunity ever to spay or neuter that animal. So, can you take an animal with mild upper respiratory disease or that puppy with mild diarrhea? Can you safely, or that heartworm positive dog that's not showing clinical signs, can you safely anesthetize those animals and perform a surgical procedure that, depending on, dog, cat, male, female, skill of surgeon, may be as short as a minute or 2 or as long as 30 minutes? Can you safely anesthetize and do surgery on that animal? And if the answer is yes, then you go ahead, because the risk is if you say no, let's wait and bring this animal back when XYZ is over, you're never going to see that animal again. In the shelter world, again, I'll reference our program. 24 different shelters, 2 mobile units. On average, we go to most shelters once every 2 weeks. Someone brings in a kitten that's sneezing. It would almost be unusual for them not to bring in a kitten that's sneezing. But someone brings in a kitten that's sneezing. I'll look at the students and I'll say, if we tell this shelter we can't do the surgery because of the upper respiratory disease, that is a death sentence. That kitten's not going to be adopted with the upper respiratory disease, and before we get back to this shelter in 2 weeks, that kitten's going to be euthanized. We spay or neuter that animal, in all likelihood, before we get back, that animal's going to be adopted. So sometimes a spay-neuter in the shelter environment, a spay-neuter is an emergency life-saving procedure. All right? And you have to weigh the risk-benefit, but recognize that the risk of not doing the surgeries in the shelter environment may very well be the death of the animal. Yes, sir?
So in regards to younger animals, I'm talking about male neutering, sometimes, you don't have the testicles in the scrotum, so you have to wait.
Why?
So you just go and do abdominal, more complicated surgery.
The question was, what about when you're doing a pediatric castration and the testicles have not descended yet? All right? So you have to wait. And my response was, no, you don't have to wait. There's a way to go get those testicles. All right. Someone in the room might have more knowledge about this than I have, but my understanding is that in the vast majority of animals, the testicles are going to have descended by 8 weeks. All right. There may be, and if they've not descended by 8 weeks, they're not going to descend. All right. So, in that animal, in that 8-week-old puppy or kitten, that you feel the testicles are not in the scrotum, a cryptorchid surgery is actually a very easy surgery. Most people were trained to consider it as an exploratory, and they open them wide open, and they do all sorts of trauma, when all you have to do is recognize where the vas deferens is, and you can do a cryptorchid castration in a puppy through an incision that big, finding the abdominal testicle with a spay hook. Bam, bam, bam. So in our environment, with the shelters we deal with, we've got a puppy or kitten where the testicles are not descended. We're going into the abdomen to get them. That may not be consistent from one environment to the next. It depends on what the shelter, the quality of the shelter, the quality of the care of the animals in the shelter. And so if you're in a shelter that provides very good care and is not routinely euthanizing for space, wait. That's not a shelter in Mississippi. Sorry, but it's not. Yes, sir?
On a really young puppy, do you use a paramedian approach to get the testicle? Like a really young one? Yeah.
Do I use a paramedian approach in those young puppies? All right. And yes, it's an incision right beside the prepuce. If it's unilateral cryptorchid, it's on the side of the cryptorchid testicle. The vas deferens always courses underneath the bladder and lateral. So you can place a spay hook just lateral to the neck of the bladder, sweep out, and slightly cranial, and the vast majority of times, 90% of the time or more, you'll catch the vas deferens and you'll pull that testicle out of that teeny little incision. And it doesn't take a whole lot longer. It does take longer, but it doesn't take a whole lot longer than a routine scrotal castration in a puppy. It does take moving them into the surgery room, which is, and we do our castrations, puppy and cat castrations, in our prep room, but it does take that, so it's a little bit more effort. You had a question, sir?
Even if they're bilateral, you usually get them out through the one incision.
If it's bilateral, get them out through one incision. The difference is, if it's unilateral, I'm going to make a paramedian incision. I'm not going to cut the penis in half. I'm going to go lateral to the penis and prepuce and lateral to the linea alba if it's unilateral. If it's bilateral, I'm going to go one side or other of the prepuce for my skin incision, and then I'm going to move over to the linea alba and do a midline entry into the abdomen, and that allows me to get to either side of the neck of the bladder. Under the penis. Yep. All right. I don't know how we got into all that, but anyway. Patient selection. What if the animal is pregnant? What if the animal is lactating? What if it's in heat? What if it has a pyometra? The answer to that is spay them. All right. The one thing, maybe the one exception is that pyometra that is very, very, very sick. It may require some, the surgery is necessary for the recovery of the animal, but it may require additional fluids and additional care prior to surgery to get the animal in shape for surgery. But there's no reason, I pull my head out, the hair out of my head when I hear people say, someone brought in a dog that was, 40 days pregnant, and so we sent them back to have the litter and we'll spay it later. Oh my God, what are you doing? No, you spay them. All right. But client communication in any environment, and maybe even more so in the high-volume spay-neuter environment, client communication is critical. All right. First off, where possible, and it may not be possible in the shelter environment, but when you're dealing with owned animals, it usually is possible, to get a complete history. The history should include any current signs of disease, any current medications or supplements, any previous vaccinations, any pre-existing medical conditions, any previous adverse reactions to anesthesia or whatever. Now, in that 90% of people that have never had their animal to the veterinarian, you're not going to be able to get all of that information, but you get as much information as you can. All right. The client communication in advance should include instructions on withholding food. It should include information about the risks of surgery and anesthesia. And it should include some sign-off that the owner understands the risks and consents to the surgery. With withholding food, we have to differentiate between the pediatric and the juvenile or adult. For pediatrics, it's never, ever appropriate to withhold food for more than 4 hours. All right, never appropriate. So those shelters that we go to, and there are some, that we're going to show up at 8 o'clock in the morning. So what do? They pull the food away from the puppies and kittens at 5 o'clock the day before. The first thing we do when we go get those animals on our mobile units is we feed them. And then we wait a couple hours before we do the surgery. All right? There's no reason to wait more than 2 hours in a puppy or kitten. And absolutely you don't want to wait more than 4. Now, the older, the juveniles, 18-week, 20-week, whatever, up to adult, it's probably not necessary ever to withhold food for more than 6 hours, but they don't have the same risk of hypoglycemia as the pediatrics, so it's acceptable to have an overnight fast for those animals. And there's no reason ever to withhold water. All right, so when they pull food away, don't pull water away. The physical exam should always be performed by a veterinarian or, in particular situations, veterinary students that are supervised. All right? It should be performed prior to anesthesia, but only if that doesn't put the life of the veterinarian at risk. All right? So we have to balance the life of the animal versus the life of the veterinarian. We all know there are situations, especially if you're working with community cats, we all know that there are situations where you can't even begin to think about a physical exam until that animal has been sedated or anesthetized. All right? The guidelines document that that is acceptable, that is appropriate in those situations. You want that physical exam prior to the surgery, and ideally you want it prior to the anesthesia, but we know the exceptions and the guidelines document those exceptions. All right. The body weight should be determined as close to the time of surgery as possible, and whether you take the temperature or do any pre-anesthetic diagnostics is really dependent upon the veterinarian and the design of that particular clinic. The guidelines don't try to tell you you should take the temperature or you should do any preoperative blood work, whatever. Again, our situation, most of the animals that are coming onto our mobile unit are stressed. Their temperatures are going to be elevated, and we're not going to look at a puppy or kitten and say, well, gee, your temperature is 103. You're going to die today because we're not going to do surgery on you. Because in our particular environment, those animals that we turn away and say, I'm sorry, we don't think we can do surgery on, we know that's a death sentence for those animals. All right, so it's probably best to take our break right now because I'm going to start anesthetic procedures. So let's take a break. Thank you.